Awesome. So these are all thyroid tumors in adults. I can send out the specific clinical histories as well as the link to the extended presentation, and the recording or whatever when this is over, of course. But this is essentially a similar thing to the interactive microscopy session that I'll be giving at USCAP this year. So, it's good practice for me, and I think it's good for you guys to see what goes on out there. So there's 9 cases total, and there's sort of a theme, but we'll go through it as we go along. So hopefully you guys can take turns sort of telling me, at least describing me what you see and what your differential is. So this is case 1.
I guess I can start.
Yeah.
Yeah, so we have a solitary, singular, very well circumscribed thyroid nodule, which is very cellular and has sort of dilated vasculature. Going to high power, architecturally, there's no papillae. The architecture here, I'd say, is, I'm not sure what's the best word to describe this. It's all composed of small glands. I don't want to use the word massenar, but it's small. Maybe tubular is a better word for it.
Follicles.
Yeah, follicular. Sure, let's go with that. In the intervening stroma, it's sort of amorphous in pink, though I'm not trying to get at amyloid, not yet. The nuclear features of the follicular cells, I mean, they look kind of like PTC nuclei to me. They're relatively cleared out. The haloing isn't perfect in every cell, but I think it's generally there. They're not that mitotically active. They seem they're moderately disorganized, shall we say. I guess if I were to look at this thing without having looked at the next 3 slides, which I think kind of have 3 sort of similar morphology, and I'm going to get sort of lost in the nuances between them. I was thinking about this. I can't call it a PTC without this papillary architecture. I'm wondering if this could be a NIFT-P. Something that's so singular and well circumscribed, that has nuclear features of PTC, but is not PTC.
Yeah, certainly that is definitely on the differential. And as you said there, the pretty much the growth pattern is nearly essentially follicular. The nuclei are arguably, there's not necessarily a normal one in sight, right? They're pretty much all kind of enlarged, kind of cleared, kind of cup shaped. Some of these I like to think of like half moons or cup shapes and kidney beans. The one sort of subtle thing that pops up, on occasion, let me see if I can find, there was one area where I was before. I don't know, that almost looked like it could have subtle papillae, but that's, that papillae are always debatable, right? So is there any ancillary technique you want to do to confirm whether this could potentially be a NIFT-P or whether you have to think more about a PTC?
I guess the one thing that could, oh, sorry, go ahead.
No, go ahead.
I was going to say one thing that could rule out NIFT-P is if you're to BRAF.
Yeah.
And if we got a RAS, would that also nudge us in the opposite direction?
Yeah, exactly. So there's dichotomous genetics. Exactly. So a RAS-like mutation would imply that it's not a conventional PTC, that it's potentially a NIFT-P, and a BRAF or a BRAF V600E-like mutation would exclude a NIFT-P and essentially rule in a PTC. Exactly. So here's a BRAF immunostain, and don't just look at it on low power, please, because as you know, it can be really subtle. So always compare the BRAF to the background.
And there's a blush.
There's a blush. There's a blush. Here's the background.
I see.
So you're going to call this positive or negative?
I guess I have to call it positive.
Yeah, you have to call it positive. So now your diagnosis is?
It's going to be PTC.
Yeah, it has to be.
Follicular variant? No.
Yeah, so great question. So two comments. One, the BRAF antibody that we are currently using can be very weak, but is generally extremely clean in the background. And so if you see any significant amount of cytoplasmic expression in the tumor, especially in this case where it's essentially diffusely present throughout the tumor, here's a nice, better area. This is positive. Dr. Venkatraman is shifting out the clones from a pre-dilute to a dilution that apparently whatever this clone is works better in the hematologic things. So in that clone, the background is a little bit dirtier. So we're going to have to change the way we think about perhaps interpreting BRAFs, but essentially the tumor should be stronger than the background, or positive compared to the background negative. Yeah. So the negative control of the internal, as Anushmita is saying, the negative internal control is very, very helpful in helping interpreting these. And so follicular variant, you know, is a term that's out there. And I do want to comment on that. But before I do, I want to show you an additional section on this tumor. So one of the criteria for NIFT-P, of course, is you cannot make that diagnosis if it has a BRAF V600E mutation. And number two, if you think something is NIFT-P, you really should investigate. Some studies say the entire lesion, not just the entire periphery, but the entire lesion, because you may find areas of architectural papillae, especially people who don't have access to BRAF immunostains or molecular, whatever, because you may find areas of complex branching papillae, which in this case, we actually had a nice area. It's sort of like a little corner, like this little wedge-shaped area here at one corner of the entire, 2-3 centimeter tumor, had these areas of very long, almost resembling kind of a tall cell structures, but more kind of complicated architecture with arguably some here. There's a papillum right there, and potentially some intranuclear pseudo-inclusions, but I'm not going to go searching for them. You'll be able to do that when I give you the slides. No, maybe there's like the start of one right there.
I see.
So yeah, so this was confirmed to be positive with genetics, so with sequencing. So this is in fact BRAF V600E mutated. So then you get into the question of how do you call this? So in the past, right, PTC follicular variant was considered, encapsulated or circumscribed, and was considered infiltrative. And many of these circumscribed follicular variants became NIFT-Ps, right? If they fit the right criteria. But the problem is, if you call this a non-invasive encapsulated follicular variant of PTC, you almost imply to some people that you're thinking it could be a NIF, So I don't think that terminology is accurate in this case. So I would actually call this a papillary thyroid carcinoma with extensive follicular growth. And that's just me. That term isn't, proposed by the WHO, but that's me, because I think the follicular variant term has become so muddied based on, is it a NIFT-P? Is it a real cancer? So if it's to me more of a conventional type of PTC, especially if there's a BRAF, like this ain't nowhere near a NIFT-P, right? So this is a classic PTC with extensive follicular growth. And then Peter Sadow sometimes uses the term prominent follicular architecture. So these terms are out there, they're being used by different pathologists. So to be determined how the nomenclature changes. But this case, interestingly, actually did have a tiny little lymph node metastasis. So like there's no way in hell that I'm going to call this PTC follicular variant circumscribed non-invasive, because it is invasive. You just don't see it, and it showed up in a lymph node, So that's my 2 cents on this tumor. Are there, you guys have thoughts or questions? Okay, awesome. Hopefully that was helpful. This was a really interesting case. Yeah, for all of these reasons. Okay. Next case, another 2.5 centimeter, 3 centimeter lesion in an adult.
I can do like a quick description.
Mhm.
So I think like predominantly this had sort of well, we have a a circumscribed, pretty circumscribed looking
Mhm.
nodule. It gets a little sort of moth-eaten at one corner or a couple corners.
Mhm.
We have a rim and normal thyroid on the edge, and then the nodule itself. I think we see a mostly kind of like microfollicular pattern. Some of the nuclei look cleared out, which I think kind of caught my eye. There's some areas that looked a little more oncocytic, if I remember correctly from this one. And then some areas that get more solid, which I guess was a little worrisome. And then some areas, honestly, that look even vaguely squamoid. I don't think we passed those, but some, I don't know if it's just getting super solid or I'm just, hallucinating things. But that was another thing that kind of jumped out at me in this one. So I wasn't quite sure sort of where we were going with this, whether this was just like, kind of this microfollicular pattern that then is becoming more solid and we need to worry a little bit about like becoming poorly diff, or I'm overthinking it. Or if those squamoid areas really are squamoid areas and this is like cribriform morular. So I was very confused, but those were some of the things kind of bouncing around in my mind.
Is this what you mean by squamoid?
Maybe here there was like one area that I got really excited about, but there's also an area with quite a few mites, I thought. Maybe this is it, yeah, but that might have been it. That might have been the only thing, and I got a little carried away.
Yeah, perhaps a touch carried away. I wouldn't necessarily refer to this as necessarily squamoid. Because thyroid follicular epithelial cells can have moderate to abundant amounts of eosinophilic cytoplasm.
Yeah. Looking at it again, assuming this was what I saw, I don't remember for sure, but but I think these are obviously just follicles that are squashed together and with plenty of cytoplasm. So good. Hopefully this is not what I saw. Hopefully it was maybe some other overly zoomed in area that I got carried away with.
Got it. Yeah. So, all right. So just to recap, then I'll get back to you. So to recap, there's mostly follicles. There are arguably compressed follicles. I probably would not regard these areas as solid because if you look very carefully, you can still make out the outlines of microfollicular structures. They are just highly, highly compressed, right? And so if you could see septations or fine lines or vessels or something that separate these areas, almost like a paraganglioma, right? Like little Zellballen, I would regard these probably as really, really tightly packed compressed follicles rather than true solid growth. We'll see solid growth later, but I would argue that this is not quite yet solid. It's just really, really, really tightly packed follicles, maybe a few trabeculae or like elongated cords. But yes, you've pointed out that some of the nuclear features are there of clearing and et cetera. So again, what is your differential diagnosis now that we've ruled out, not some kind of cribriform morular, not some kind of anaplastic? What would our differential here be?
So I mean, again, if we are worried about the nuclei, I suppose, so just like based on the cytology plus this more kind of follicular looking growth pattern, I guess it could be an FP in this case. And so again, the stains would be nice and helpful, or molecular workup would be.
Right. Yeah. So to your point earlier, this is BRAF negative, easy in our institution to do the stain because we have it. And Reham, I think we do have PTC nuclear features, exactly. And so that's the dilemma here, right? Is so the PTC nuclear features in this case are, similar, but maybe not quite as well developed as in the other case. There's definitely elongation, there's grooves, there's clearing. This case had a RAS mutation. So to me, H, N, or KRAS are, to me, indicative of, as I said earlier, not a classic or a conventional PTC, but would, in my opinion, be supportive of a NIFT-P, because we know that RAS-driven neoplasms are biologically more of follicular neoplasms, follicular adenoma, follicular carcinoma, and as long as there's no invasion, like you cannot really call this a carcinoma, and so that is in interesting and stark contrast, right, to the case we saw above, which also had no obvious, capsular or vascular invasion, but there are subtle differences between these two cases. One, some people use, very rich, dense colloid with scalloping as evidence of conventional PTC. I think that's kind of a soft sign. Certainly abortive papillae. So even in this case, there's little tiny projections into the lumen that could be considered abortive papillae. So, number one, subtle morphologic differences are present, but, don't always necessarily convince you enough in one direction or another. But genetics I've found to be extraordinarily helpful. And in most cases, genetics can sort tumors out into lesions that are, PTC, BRAF, V600E-like or RAS-like. So yeah, this is a NIFT-P. So does anybody remember the specific criteria for diagnosis of NIFT-P? At least the published criteria.
Like absence of nuclear features of PTC is one.
For NIFT-P?
Presence, not absence.
Oh, sorry, presence.
Yeah, okay.
Yeah, I'm so sorry.
All right, what else?
Papillae less than 1%.
Follicular pattern.
Mm-hmm. Technically, the paper says 100% follicles, okay.
Papillae less
nuclear.
than.
Is being encapsulated. Or I guess, yeah, Sturdom's right.
No necrosis.
Mm-hmm.
No necrosis, no invasion.
What else? No necrosis, no invasion, no.
No,
mites.
papillae less than 1% or something.
Yep, so it changed. The original paper suggested less than 1% papillae was okay, but actually now they've said 0 papillae. So let's just go with that, 0 papillae for now. Because I want you to know the textbook definitions. So let's go with that.
All right, if no papillae, then also no pseudomoma bodies.
Mm-hmm. What else?
No BRAF, although I don't know that that's like
Yep.
official.
that's
Oh, really?
it.
Is that part of the official?
That's part of the revised criteria. Yep. It's a suggested exclusionary criterion because not everyone has access to IHC or molecular, but everyone has access to H&E, right? But if you have access to IHC or molecular and it is BRAF positive, it is not a NIFT-P. So correct, BRAF V600E is exclusionary. What else?
And then
RAS?
together with
RAS mutation or
No. To
Can I-
include or to exclude?
include?
It is not part of the criteria. It is part of my criteria, but it is not part of the textbook criteria.
Okay.
So we'll put that on the bottom. All right. What else?
together with no necrosis or invasion, no mites.
Mm-hmm. Do you remember how many they say?
Less than
What?
3 per
If-
10 high
if-
power field.
Yeah,
Thank-
so
thank you.
they say no more than 3 per 10. Okay. What else?
That's what I got.
There's one more thing. Trabecular or solid growth. They say no more than 30%, which, don't know where they came up with these numbers. Don't know where they came up with the 3 mitoses per 10 high power fields, and don't know where they came up with the 30% trabecular or solid growth, but these are the criteria. So exactly, essentially 100% follicular, 100% follicular growth, meaning 0 papillae. I guess theoretically you could have up to 30% trabecular according to these criteria. Presence of sufficient nuclear features, meaning a little wrinkle here and there, a little groove here and there, but mostly normal nuclei. You could call it benign, technically, but really no necrosis, no lymphovascular, capsular, perineural, no any invasion, no papillae, no pseudomoma bodies. Some people have actually argued also no true pseudo inclusions. All right. No BRAF V600E, no increased mitoses, and little trabecular to solid growth. So if you are in practice and arguably this lesion in the background would fit. You know, the question comes when you have a small papillum here and there. Is it a true papillum or is it a hyperplastic type of papillum? Is it, do you have a true Samoma body or a not true Samoma body? Do you have a true pseudo-inclusion or a, not really robust pseudo-inclusion? So if you have strict criteria, you'll probably do fine. But even on borderline cases, to me, the presence of a RAS mutation, regardless of if you have, I don't know, 40% solid growth or trabecular growth or 4 mitoses, like if you have a RAS mutation, to me, like this is not a conventional PTC. And so again, the only molecular that's included in the true literature is the exclusion of BRAF V600E, but there really is no comment on inclusionary criteria for NIFT-P genetically. There is a group out there, myself included, that does believe that the presence of a RAS or a RAS-like mutation should effectively discard or disregard a tumor from being a variant of papillary thyroid carcinoma, because we know that molecularly and behaviorally, these are different, right? These RAS-driven tumors do not go to lymph nodes. They are not locally, metastasizing neoplasms. They are locally recurring. They are distantly metastasizing, like the lung, et cetera. But in the absence of any invasion, it's very hard to call a RAS-like neoplasm a cancer. Unlike with a BRAF mutated neoplasm, these biologically are much stronger drivers. BRAF is 100% cancer, right? RAS is not 100% cancer. RAS could be benign and RAS could be malignant. Does that all make sense? Okay, great. Sorry to belabor this point, but I think it's important to know, what people out there in the world say and what how we can frame it. All right, let's move on since we're already at 8:25. All right, but those were kind of the big points, things you're going to see day to day. All right, next, also circumscribed, also some inflammation in the background. Also some slightly enlarged, slightly cleared nuclei.
It's a very nice papillary area over to, I think it's the right-hand side.
Mm-hmm. Yeah, there actually is a papillary area here.
Yeah, and it doesn't look like it's unlike the other two encapsulated. It's like it's breaking free. So already we know it's not.
Yeah, so it's an interesting morphology. It sort of depends where you draw the line, right? Like
True.
It's like it's budding off of the
it's like like the follicular carcinomas that kind of like bud out basically, but
yeah, it's like, do you draw the line here or like do you draw the line here? They're right, you're right. There's like this weird bud.
Were they colliding? Like I don't know.
I don't think they're colliding. I think this is all the same tumor.
It's coming
because
out.
It essentially connects.
Like pooching out of there, yeah.
Yeah, pooching out. But there's this pooching out area that certainly has papillary architecture, and some subtle nuclear features, even if we don't see, definitely pseudo-inclusions. One of the criteria for PTC that I also think is important to think about, but is not really mentioned so much is cytoplasmic characteristics. So, here the cytoplasm is not really dense or abundant or eosinophilic, but that is a good criterion for PTC. So abundant, dense, eosinophilic cytoplasm with well-defined cell borders is actually kind of a nice definitional diagnosis for PTC. What this does have is this kind of dense colloid with scalloping, like we saw in the first case and not in the NIFT-P. And so, all right, I'm going to do a BRAF immunostain on this case because that's our protocol and it's negative. So then what do you want to do? Are you good calling it PTC, or you want to step back and call it a NIFT-P? You want to do molecular? Some Samoma bodies in that first field, question mark. We have a vote for PTC. We have a vote for invasion. So it looks like you guys are kind of leaning towards PTC, or you may want to do molecular. Yeah, so this was an interesting case for me because it didn't neatly fit the box. You know, it didn't have the very robust nuclei of PTC. It didn't have pseudo inclusions, but it had this, you know, weird pooching out area with papillae. Yeah, so this molecular was done on this case. And let me just pull up my answers here because I forgot what it had, but it had I don't want to lie to you. It had a SND1 BRAF fusion, SND1 BRAF fusion. So how do you interpret that?
Variant BRAF abnormality.
Yeah, maybe just not the one that we have the clone. It's not the BRAF V600E. I guess that's.
Yeah, so first, it's not a point mutation, it's a fusion, correct? So the immunostain would not work in this case. And pooching thyroid carcinoma, exactly. So whenever I don't know what a genetic anomaly means, I tend to go to the literature, and one of the best sources is the TCGA paper on thyroid. Is that a fire alarm? No idea.
Heard someone.
Certainly is not me. I'm at home. So, oh, coag lab, great. Well, it's probably just
sounds
a
like the-
drill. Unless you're scared, you can leave. I don't think I've ever left when I've heard a fire alarm ever. But you guys do what you need to do.
Too much asbestos in the walls. We're saying.
Exactly. I'm going to keep lecturing. So the TCGA study basically says that any thyroid lesion with a BRAF fusion is papillary thyroid carcinoma V600E like. So BRAF V600E like neoplasms end up, of course, being those with BRAF V600E mutations, but also those with BRAF fusions, with NTRK fusions, with RET fusions. So this is in contrast to the RAS-like, which are things like PAX-PPAR gamma fusions, BRAF K601 mutations, or insertion deletions. All right. So BRAF is not created equal. BRAF V600E and BRAF fusion tumors are thought to be PTC-like, you know, and BRAF K601 is a very specific allele that is considered part of the RAS-like family. So very interesting, but I always search the literature when you have a variant, because most of them have been categorized into one of these two groups by the TCGA paper. So yeah, so this had a BRAF fusion. So regarding this as more of a PTC. So all of you guys who picked up on those features like the pooching, the invasion, the papillae, all of you were correct in hunting out those morphologic features. Great job. Questions?
This one's a little different.
Yeah, we're shifting gears a little. So somebody.
If people don't mind me describing again. So again, another solitary, well-circumscribed nodule. Architecture is a lot denser this time. It has sort of a two-toned appearance. I'm not sure what to make of the pinker area in the center compared to the outside, but you see the same architectural features in both.
Yeah.
It's not quite solid. It's not follicular. We don't. Well, I mean, maybe there are. You can find like the lumens periodically, but by and large, I would call this sort of trabecular, or dare I say, insular growth.
Yeah, sure.
And I guess Raham makes a very good point, is that these things, there is a very oncocytic morphology here with kind of granular cytoplasm and very round nuclei. Funny, because of the architecture before Raham said that, I was going to start putting this in like a solid, poorly differentiated category, but actually looking at it, it's not very mitotically active. It's very dense, hypercellular, but it's otherwise kind of bland, isn't it?
Yeah. There's maybe like one mitosis. I'll give you one.
Yeah. So I'm going to stop talking now.
Okay. Yeah. So oncocytic. With trabecular, I agree. I think that this is actually pretty nice trabecular growth because the divisions between the areas of cells are actually quite long, right? And you don't really see colloid in some of these. So yeah, this is actually very nice trabeculated growth. And I will say that Hürthle cell neoplasms like to grow in that fashion for reasons I do not know. Yeah, there's occasional colloid here and there. But if you see trabecular growth in a Hürthle cell neoplasm, like that is very, very common. So it's okay. It's okay. What else do we see? We don't see mitoses very much. We don't see necrosis.
Like, is there an area of invasion in this?
Pardon?
Like, do we consider this invasion, or is
Ah.
it still?
Do you consider this invasion?
I think so, because I see normal colloid
Mhm.
follicles surrounding it.
Yeah, so exactly. So even though it's extremely well circumscribed in most areas, there's perhaps a fine capsule, and we have a few votes for invasion. And this out here, I would argue, is completely on the other side of the capsule. And it's basically touching, like you said, it's basically touching normal thyroid. So yes, I would regard this as a focus of capsular invasion, even though you don't see the stalk, right, of the mushroom. You know, we don't necessarily have to have a stalk. We might just be cutting through it in a plane where the stalk is absent. But yes, if you have a nodule completely on the other side of the capsule, I agree this is invasive. And yes, this would be a Hürthle cell carcinoma. So I believe if you look around, you know, if you are ever uncertain, do levels, do deepers. If that focus persists and persists and persists, yeah, you can be even more confident. Oh, look, here's another tiny little area that's outside the capsule. And so this is probably the, you know, minimalist amount of invasion that you can get. Oh, look, there's maybe a third area out here. So yeah, so this is a Hürthle cell carcinoma. As long as you don't fit the additional criteria for poorly diff, which we'll get to, like, you know, increased mitoses, necrosis, etc. Yes, this has trabecular growth, but it doesn't have any of the other features like mitosis and necrosis. So yes, this is a Hürthle cell carcinoma. Yes, this is, would you regard this as minimally invasive, widely invasive, angioinvasive?
Minimally invasive?
Minimally, yeah. So minimally invasive should have only capsular invasion. All right. Once you start having any angioinvasion, even if it's one vessel, now you have an angioinvasive carcinoma. So let's say one or more vessels. And widely invasive is such that has sort of diffuse, extensive intra and extrathyroidal invasion. All right, so we're certainly not there, but we are at a minimally invasive Hürthle cell carcinoma. There's a nice diagram in the College of American Pathologists protocols, you know, the ones that you can get free online, that kind of describes the accepted. Why is invasion happy? That's a good question. I could change those to plus signs instead of happy faces. So yes, invasion for the happy faces, and no invasion for the red lines. But I adapted this diagram off of the CAP protocols because I thought the diagram was very nice. But it was a little old-fashioned looking. So I updated it, and I've provided this here for you to understand what really is okay for capsular invasion. The one thing that I think we need to be cautious about, I think the rest of these are obvious, like, oh, it's poking through the capsule. Oh, it's on the other side of the capsule. Oh, it's completely mushroomed through the capsule. The one to be careful of are these ones that pseudo, like secondary capsulize, where you have complete, you know, transgression through the capsule, and you have tumor cells on the other side of it, but then it has developed its own little like mini capsule. I think these are probably the hardest ones because you're like, oh, there's a capsule on the other side, but you sort of have to draw your lines, that your lines of demarcation, your DMZs, to figure out sort of where does the tumor end and where does the normal thyroid begin? So other than that, I think these are pretty conceptually straightforward. Whether they are straightforward in practice or not is another, issue. Okay. How about the next case?
I can go ahead and
Okay.
take a stab at this. So yeah, I guess if we were to draw a line around it, the line is going to be a little wonky. So it's probably, whatever this tumor is. Yeah. Okay. Ram's just straight up is like, it's a Hürthle tumor. Yeah. And I would agree with her. Like, the cells are, again, very oncocytic looking. Nuclei are, maybe nice and there's some nucleoli.
Yeah, which you would expect certainly in a Hürthle cell. Mhm.
Yeah. And they are growing in like nice trabeculae too. There's a lot of, I don't know why this is the case, but there seems to be a lot of blood in this one too. Maybe it's just procedure related, but it's really not the biggest deal in the world. But yeah, unlike the other one, it is like sort of breaking out here. There's a lot of hemosiderin here as well too, which was interesting. That could just be from like a biopsy potentially, and then it got scarred over. Yeah, and then there's like this little blood leaks too with papillae. So
Yeah.
Yeah.
So Hürthle cell lesion with blood, with fibrosis and hemosiderin, and Riham is saying question mark infarction. And then there are these lakes with, as you pointed out, arguably some weird pokey sort of looking like papillae. Are we going to regard this as biologically important for papillary carcinoma, or are we going to disregard these?
I'm going to disregard these. Yeah. So.
Great. Because when you get a Hürthle cell neoplasm that's quite florid like this, I don't think that you're really thinking about this being a papillary carcinoma. So we can regard these as architectural kind of artifacts. That's fine. So then how do you, you're right. So then how do you interpret the fibrosis, hemosiderin? Is this, is this invading through a capsule, or is this FNA infarction?
Yeah, I guess, it probably is more FNA infarction, because this can happen where you get this like scar, so it looks like it's invading through a capsule. But yeah, I guess there's a lot of hemosiderin, which sort of makes me think it's more due to FNA infarction than actual.
I feel like you can imagine.
Capsular invasion, yeah.
Sorry, I was saying I feel like you can imagine like the needle sucking portion of the tumor out like through that little hole. It looks like one of those fish that have like little kissy mouths or something. Like you can see it like squeezing out.
Yeah, so exactly. So I'm not sure that you would be wrong either way. I agree with you guys. I called this, post biopsy changes, and I called this benign. But one, if you think that this is a capsule, and you think that this is capsular invasion, and you think that this is minimally invasive, okay, put that in your head. That's a possibility. If you think that this is all fibrosis that is occurring within the lesion because of FNA, I sometimes call that intra-lesional fibrosis, okay, rather than a capsule, intra-lesional fibrosis. So you can call this, benign Hürthle cell with intralesional fibrosis. You could call this minimally invasive Hürthle cell with capsular invasion, or you could call this atypical Hürthle cell neoplasm with fibrosis, favor FNA infarct. Because Hürthle cell neoplasms are so sensitive, unlike regular follicular neoplasms, they're so sensitive to FNA. Weird things can happen: hemorrhage, infarction, architectural irregularities. So I'm a little bit cautious with Hürthle cell neoplasms, but the good thing is minimally invasive Hürthle cell carcinoma, or for that matter, follicular carcinoma, atypical, atypical Hürthle cell neoplasm or follicular neoplasm, and, benign, infarcted. Is the treatment going to change for any of these?
No, I think it's all surgery, basically.
Exactly. It's all surgical resection. Once they're done with surgery, which obviously once it's on your slide, they're done, and observation. None of these patients should undergo completion thyroidectomy. So we're going to X to completion and an X to radioactive iodine. Because capsular invasion only without angio invasion is so indolent that nothing to be done. So regardless of your diagnosis, the most important thing to get across to your clinical colleagues is, no additional treatment. And so that's why I'm very cautious in these. And so I may have said atypical Hürthle cell neoplasm with fibrosis, favor, post biopsy, because, some amount of caution is fine as long as we know how to treat the patient. So that's my caveat on that. Hürthle cell neoplasms don't always maintain the same genetics as follicular neoplasms. They often have nothing. They often have mitochondrial DNA mutations, which we don't assess for. So if you don't find any molecular, don't be surprised. All right, next.
The way this was submitted makes me think there was suspicion for FTC or something. A lot of capsules.
These nice little strips, exactly.
Yeah, it's pretty densely blue in some areas, fully like normal sized follicles in other areas too. I don't know if that's just residual normal that's there or part of the lesion. Seems like it's within the capsule though.
Yes, extremely densely blue and appears to be within the capsule. Okay, good. So thing one, I'll pause you there and I'm going to make you continue. But thing one, areas like this, fine, follicular neoplasm, we will evaluate it. Areas like this, where you start to get sort of sheets of cells with follicles percolating in between them, concern yourself, okay? So concern yourself with areas that are now wall to wall with capillaries on left and right. I like to think of this almost like a hepatocellular carcinoma, where you have expansion of the cords, right? And lack of architecture. So I've walked through 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 cells without another vessel or without colloid. Yeah, this is now starting to be solid growth, okay? So that's the difference. And please concern yourself with solid growth. So when you see areas like this, yep, go back and submit the capsule. Okay. So as we walk along the capsule, do you see anything that worries you?
I mean, yeah, that area.
I'm just going to go to it. So whenever you see satellite nodules, whether they be within the capsule or outside the capsule, go check them out.
Yeah, I'm trying, yeah. Because when you see this, it's like you definitely want to see like vascular invasion, rule that out, and kind of the way
Yeah. So how do you determine biologically significant vascular invasion? And this is it. So this is it. But what are the features that you're seeing?
It's like within the lumen, you kind of see the red blood cells and probably some fibrin kind of attached to this chunk of tumor.
Yep. So this
is a thrombus, yeah.
Yeah, exactly. There's thrombus and there's potentially, there's endothelial lining and there's adherence to the endothelial, to the vascular wall. So if you were concerned, you could certainly throw like a CD31 on here, but I would argue if you look closely, you'll see endothelium lining the tumor side and you'll see endothelium lining the vascular wall side, and you can follow that around. So flattened endothelium on the left, flattened endothelium on the right. So this tumor is endothelialized, it's within a vessel. It has fibrous adherence to the vascular wall with in these pink areas. And there's also a little associated fibrin thrombus kind of out here in a satellite vessel. So yeah, so this is biologically true, significant vascular invasion. And some of you who are saying follicular carcinoma, yeah, I think that's the diagnosis here. And so now, is this minimally invasive, widely invasive, or angioinvasive?
At least angioinvasive.
At least
We thought too.
angioinvasive, exactly. So based on these three sections, there's nothing else. But you certainly would want to go and evaluate this thyroid quite convincing, thoroughly. Once you start seeing these areas of solid growth or trabecular growth like we saw before, then you of course have to start thinking about, is there any way that these solid growth areas meet criterion for poorly differentiated carcinoma, right? So don't stop at follicular angioinvasive. Think, could it be worse? Okay, could it be worse? So we'll see what worse looks like in a second, but always think about that. So this is at least angioinvasive follicular thyroid carcinoma. So my angioinvasion is also happy. So, you know, when you have floating tumor in a vessel without endothelium and without thrombi, this could just be push, a fragments artifact in a vessel. When you have pushing of a tumor nest into a vessel with endothelial undermining, this is also not considered invasion. Some people also do not consider invasion when you have endothelialization without fibrin thrombi or adherence, because this could be just like an intussusception, right? If you think about how Samoma bodies work microscopically, this could also be how, you know, vascular invasion works grossly. Because if you have a vessel here and you have a tumor and you cut through it like this, you know, that's going to look like vascular invasion, but really it's just an exuberant form of this, right? It's just kind of intussusception of a tumor like finger that's pushing underneath the endothelium, not actually invading into it. Does that make sense? Once you have adherence to the wall by fibrosis, by fibrin, with or without endothelium, these are all considered biologically a significant angioinvasion, and they should all be regarded as angioinvasive follicular carcinomas. This is a little bit more controversial. People out there have different definitions of angioinvasion, but this is the one that's promoted by the CAP. So this is sort of what I use. Once you have an angioinvasive carcinoma, what's the treatment? Same or different than minimally? The whole, exactly. So these patients will often get completion with radioactive iodine ablation, because once you're in a blood vessel, you have a significantly increased risk for visceral, pulmonary, bone, brain metastases. So yeah, these patients get the whole. Okay, next. Somebody who hasn't spoken yet, even if you don't have a diagnosis, even if you could just describe.
I didn't speak, so I could
Thank
go.
you.
Sure. So yeah, so here it is kind of almost normal looking. I'm not sure, but here, like microfollicles, I'm not sure if we have any nuclear features of PTC, but it looks okay for now.
Yeah,
Yeah.
pretty round, pretty
Yes.
regular.
Yes. And in comparison, we have at the left here, we have a problem, or we have pathology here.
Yeah.
It's more solid.
Yep.
Like we are not able to recognize. No, we see microfollicles, but it tends to become more solid.
Yep. Again, right. You sort of walk from side to side and you don't encounter a lumen. So good. There is at least focal solid. Yep. Good.
Yeah. I'm not seeing any. I'm not sure if this is necrosis here, or just.
You certainly should think about it. All right. We'll keep looking.
Yes. And extensive fibrosis here.
Mm-hmm.
But it could be the site of prior FNA.
Mm-hmm. Mm-hmm. Mm-hmm.
but I believe it's invasive. Yeah, here we have necrosis,
Yeah.
right? Yeah,
Yeah.
we have necrosis, and the tumor is it's invasive. So
How do we
for
know
me,
that?
like it goes to the normal parenchyma, right? It's not well demarcated, and it's pushing borders.
So that's the one thing I'm going to argue on this slide. I'm not sure about. So yes, there's a pushing border, but I would actually argue that there's a rim of normal here that seems to be pushed aside. So is that intrathyroidal invasion? Is that pushing capsule? That's actually really, that's a challenge for me on this slide.
Yes.
But what I do know is that there is a shift, right? There's a transition between this more follicular pattern growth and this more solid growth, okay? Which I think you clearly pointed out. There's
Yes.
fibrosis and hemosiderin, which could be FNA, but when you
Yeah, we
start
have
to see,
necrosis.
go ahead.
I agree with you.
Yeah, when you start to see this punctate tumor necrosis, where you have ghosts of cells with karyorectic and neutrophilic debris that is surrounded on all sides by viable tumor, this is not FNA, all right? Maybe this down here is FNA, I don't know, there's cholesterol, etc. But when you start to see these punctate areas of cell death, even like here with neutrophilic infiltrate surrounded by viable, that is true biologic tumor necrosis, okay? So if you do not believe that this is invasive based on the sections that you already have, I mean, obviously you don't have just one section of tumor, you're gonna have many, but please don't ignore this. If you do not think that there's invasion, go back and submit more, find the invasion. And if you don't see the invasion at all, I would argue that you should still be very worried about this, because solid growth with tumor necrosis is not something that you should see in indolent behaving neoplasms, okay? So if you did convince yourself that there was invasion in this patient, then what's your diagnosis?
So like, I would think about something poorly, like poorly differentiated thyroid carcinoma.
Yep.
Yeah. And
absolutely.
I'm not sure about the mite, if we have any mite here.
Yeah, so you may or you may not, but in this case, do you need it? Do you need them?
I think no. I mean,
no.
The type of like it's more solid, and the presence of necrosis would make us think about poorly differentiated, like carcinoma.
Yep.
And we should sample. We should get more sections.
Absolutely, get more sections. So don't ignore that solid growth. Don't ignore the necrosis. Get more sections. Shroud of Turin. So what are the Turin criteria for poorly diff?
Insular, as I remember.
Yeah, like the architecture. So
yes,
like insular versus solid.
Yeah, necrosis.
Trabecular as well.
Or trabecular, right? I think there's 3 patterns.
Yeah.
Necrosis for sure.
Yeah, and then like how ugly it is. So necrosis or mites or cytology, kind of.
Absence of PTC nuclei.
Convoluted.
Yeah. And the one that Manisha said that we're missing is,
And as I remember, like even presence of one focus of necrosis, it's unacceptable, like all the time. As you said, it's we should.
If you think it is true tumor necrosis, not FNA infarct, yes. And that's, so if you have strict criteria, one focus of tumor necrosis in these contexts is enough, because really, how often do we see true tumor necrosis in thyroid neoplasms? Hardly ever. So when you see it, it's bad.
Okay.
So Turin poorly diff means the presence of insular trabecular or solid growth, the absence of papillary carcinoma-like nuclei, and the presence of either necrosis or mitoses, this being, here's where the 3/10 actually comes from, 3/10, or quote unquote convoluted nuclei. And so what convoluted nuclei, I would argue, are sometimes the most challenging to identify, but they kind of look wrinkled and raisinoid, almost like coilocytic. I'm not sure if there's any that are very good in this this example, but yeah, they're just dark and wrinkled and raisin-oid. That's my best description of convoluted. So, okay. What am I trying to show you here? Oh, okay. This is the next case, 858. Do we have time?
We do.
We
We
only
have
have
2 minutes.
Yeah, we have 2 cases left. Okay, so arguably also solid.
Yeah, I thought there are some insular areas in this tumor as well. Maybe
Yep.
like large insular thick trabeculae that are forming solid areas.
Yep.
And I saw some convoluted nuclei in this. So I actually thought of this as poorly differentiated carcinoma as well.
Okay.
And I thought there was some necrosis in some areas.
Yep.
Yeah.
You're not entirely wrong, but I'm going to point out one thing because I found it.
Pseudo inclusions.
Pseudo inclusion.
Yeah.
So I was lucky enough to happen upon that. So yeah, so we're going to talk about how the subtle differences between poorly diff and this. So this has solid growth. Yep, this has trabecular growth. This has, one might argue, still some evidence of PTC nuclei with inclusions, with clearing, with overlapping, with irregular borders. So these to me aren't those dark raisin-oid nuclei of convoluted. These are more of the open, large, kind of almost voluptuous, right, nuclei of papillary carcinoma. And you might argue that we've seen at least one, pseudo inclusion. So then what do? All right. So you have something that looks quite aggressive. Like, I completely agree with you. I'd be worried here about, a quote unquote poorly diff. And there's like giant zones of necrosis here with ghosts of tumor cells. Okay. So, so how do we regard this? Is this PTC with necrosis? Is this, here's actually a nice area that's a little better differentiated for papillary. Okay, so we're probably coming from a papillary carcinoma, but we're developing solid growth and we're developing necrosis. Just for my own education, this was an old case. I wanted to do a BRAF stain on it, so I did, and it's positive. So this is a BRAF V600E, derived tumor. I forgot to mention that the one right above it, the poorly diff, is not BRAF. It is RAS with a TERT promoter mutation. So we'll talk in a second about the differences between those genetics. But what I wanted to point out is in the new WHO that is coming out, sorry, it's 901, but I want to finish this, at least this case. So in the new WHO that's coming out, there will be this new term of high-grade follicular-derived carcinomas, in which we have either poorly differentiated, which we saw before, or differentiated high-grade carcinoma, which we see now. So the Turin criteria, as we've discussed, are listed on the left. The criteria for differentiated high-grade thyroid carcinoma are basically any growth pattern, follicular or papillary, any amount of invasion, retention of PTC nuclei, right? So you don't have to check off the architectural or the nuclear, you don't have to check off the architectural features, but you have to have mitoses greater than 5 or necrosis. And so the case that we saw here arguably has papillary architecture, solid architecture, and necrosis. And so this would be a quote unquote high-grade differentiated thyroid carcinoma that is also I didn't really look for mitoses, but I can't tell if that's one or not. They're potentially there if we look for them. I didn't though in this case because we had necrosis. It's high grade. So both of these types of tumors are thought to be behaviorally worse than well-differentiated thyroid carcinomas. So your concern that this represented poorly diff was absolutely on the mark. But technically, if you follow the criterion, they are separated into the poorly diff, which fit the Turin criteria, and the differentiated high grade, which do not quite fit the Turin criteria, but are still equally bad. So one thing I did not put on this chart, which I will add, oh shoot. Come on, is the fact that mostly the poorly differentiated criteria that fit the Turin come with RAS mutations and are generally from like a pre-existing follicular type of carcinoma. Usually, more often than not, the differentiated high-grade carcinomas come from a BRAF and are more of a PTC background. So the pathways for aggressive behavior in thyroid carcinoma are different between whether they are of RAS/follicular origin or whether they are BRAF PTC origin. The morphology is slightly different, but the presence of mitoses and necrosis is essentially the same. So does that all make sense? Go ahead.
Saying that, yeah, it does make sense now.
Good, thank you. So this is new, you know, this is new. In the past, we might have called this case. In fact, this case, I believe, was called solid papillary thyroid carcinoma with, you know, necrosis. Like, ooh, this is bad. But now we wouldn't just call this solid papillary carcinoma with necrosis. We could actually call this high grade differentiated papillary carcinoma. So just an interesting kind of aside on how this shift is taking place, like right now. Whether you have an underlying RAS or an underlying BRAF mutation, if there is additionally the presence of TERT promoter mutation, these are thought to be compounded biologically. So RAS plus TERT or BRAF plus TERT are thought to be worse biologically than either three in isolation. So as I may have mentioned to you before, this true Turin poorly diff had RAS and TERT. This was an older case, so it did not actually have molecular done. We know by the immunostain that it has BRAF. I don't know whether it also has TERT, but those are just things to keep in mind. Questions? All right. Do you want to do the last case or do you want me to do it next time?
We could do it. I mean, I don't know.
Okay.
We could probably
Yeah,
fly
for
by
those of you
it,
who are
but-
still here, let's do it.
Yeah,
And
we're on a
it'll be-
roll.
It'll
So
be
yeah.
recorded. Awesome. So cool. I mean, it looks kind of bad, right? It's big. It's got a lot of fibrosis. It's got some calcs. It's got some follicles. It's got some papillae. Anybody want to shout out what they think? Does it have very, very convincing PTC-like nuclei?
Yes. we
Yeah,
have- Yes. But very poorly differentiated.
yeah, so maybe this is more the anaplastic.
It's like adeno of the
Adeno,
colon
yeah.
or something.
Oh my gosh, it looks like adeno of the colon, right? It looks like it's just kind of interesting, isn't it?
Yes, it looks like it does not belong here.
Thank you, Perry. It looks like it does not belong here. So
Columnar
know-
something.
go ahead.
Columnar, like it's kind of, the shape of the cells are unusual for like regular PTC, like they are more columnar. They look like-
Columnar.
yes,
Or at least, yep, the nuclei are kind of oval.
yeah.
So, yep, you can keep talking.
Do we have any
Yes.
history on this patient?
There is variant of PTC, as I remember, columnar cell variant that could look like something related to intestinal or bowel.
Okay.
Do we have any history for this guy?
She's I think she's in her 20s or 30s. She has a
Oh.
thyroid mass
Okay.
and she had an FNA and the FNA was called PTC.
Yeah, I feel, isn't for columnar, is it maybe more pseudostratified than this would
Yes,
be? So probably not the columnar cell variant.
right.
There's like
It's
the
a little
tall
bluer, it's a
cell.
little more elongated and it usually has sub or supranuclear vacuoles. This
Doesn't really have
while the nuclei are occasionally elongated, I would argue that the cells are not very columnar, and they do not have those vacuoles, but it's a good thought. Okay, what else were you saying? Tall cell?
Yeah, because they're not, are they 2 times as tall as they are wide? Maybe in some areas, but
In
not.
areas. What also should tall cell have?
It should be more is.
It should be
Isn't
very
tall cell is like
eosinophilic.
pink and the other one is blue.
Yep, tall cell is very pink, columnar cell is very blue. This is kind of, I don't know,
More blue.
purple.
Um,
But
It should be for tall cells, it should be like more tall than wide.
yep,
It's, I
Correct.
remember 2 times or more tall than they are wide.
correct.
And
And
they
this
should
is-
be oncocytic.
Mhm.
And this
Or-
isn't cribriforming, right?
It's perhaps not exactly cribiforming, but you can definitely perceive that there might be a suggestion of some subtle back-to-back glands. So I
Hmm,
would say perhaps.
okay.
Yeah, I see there's a bunch of stains. So I mean,
Yeah.
if they're performing, could we do like?
She did.
Yeah.
So,
What's the site of
yeah,
this?
she doesn't have a like desmoid tumor or something.
Yeah,
She
right.
doesn't have a desmoid, but that doesn't mean she can't. This is totally intrathyroidal, right? So here's the background kind of thyroid with some inflammation and almost like oncocytic. Yeah. So yeah, you guys are really on the mark with, is this a variant of PTC? Is this something else? The one thing that bothered me was for a PTC, these nuclei are all like nearly perfectly oval. They all have kind of moderately stippled chromatin. They all have small nucleoli. Like, where are my significant grooves? Where are my wrinkles? Where are my cup shapes? Where are my pseudo inclusions? Like, where are they? Like, these
Yeah.
nuclei are just weird.
Not convincing. They are not convincing to
Just
like
weird.
PTC.
But there's papillae, like there's papillae and there's follicles, like architecturally it could be PTC and it was called PTC on FNA. So yeah, okay, you want to think about columnar cell variant, which I think morphologically we can probably exclude, but what are the 2 immunostains that columnar cell stains for generally?
Oh, CDX2. Yeah, I remember this.
CDX2 and ER. So you could do those if you wanted. What do tall cell? Tall cell is generally positive for what?
Like regular TTF1.
Yeah, but yes, TTF1 and PAX8. So you might want to do a TTF1 and a PAX8 to prove that it's of thyroid origin. But tall cell also generally has BRAF, right? So if you want to say, all right, let's do TTF and PAX8 and BRAF and see if it's thyroid. Okay. What else? You said so columnar and a metastasis from colon would all have, this, but she's young. She probably doesn't have colon cancer. You said cribiform. So what do we
Like
think
a
about with
beta
cribiform
catenin?
morular?
Yeah,
Yep,
like Heather's saying.
Okay. All right, great. So let's see what we have here on the immunos. I can't remember in what order I put them, but let's see if we can figure it out. All right, this is staining the background thyroid. So this is either TTF1 or PAX8. Fine. Negative. I think that's TTF1. This is also staining the background. So that must be PAX8. Tumor. Okay. How do you interpret those? think this was thyroglobulin, even though I don't see any. Oh yeah, yeah, there's background residual. So this is thyroglobulin.
Kind of negative.
So the tumor is like dead negative.
Yeah, for what, and this one was.
So here's
Paxil.
TTF.
That's negative.
Everything is
Mm.
negative.
Here's
Yeah.
PAX. Here's
Could it
PAX.
just be
Oops.
Pax 8 negative.
anaplastic? I don't know.
And what's
Did you-
this?
Metastasis.
Sorry, that was TTF,
Oh.
that was Paxate, and this is thyroglobulin. So, okay, metastasis potentially from,
Mm.
From where? We don't know.
Yeah, actually, I
Oh.
was going to say GYN. I was wondering, right? And Ryan just said that here.
Papillary.
She's so young. But does she have like a teratoma?
she has
Her
nothing
sister.
else in her body. She has this tumor in her thyroid, and she also has metastases to neck lymph nodes. So following the pattern of, you know,
Salivary, something
Yeah.
salivary.
Like that with the intestinal type. No.
Salivary gland, maybe?
salivary gland. Okay, so potentially salivary gland. Why do you say that? That's a good thought.
Because I mean, I'm trying to just think about the area, head and neck.
Yeah,
So I'm thinking
good.
about salivary.
Mhm. Yeah, so, all right, so one, yes, you can get metastases to the thyroid. Don't ever exclude that possibility. With Paxate negative, I would assume probably not GYN. I did not do WT1. But when I thought about salivary, I thought about the fact that this is sort of cystic or microcystic to papillary with kind of a single cell type and these kind of ovoid open nuclei. So I did an S100, which unfortunately didn't really help me much. And I did a mammoglobin, which is at least focally positive. This was an outside case, so I can't account for the bad staining. But
Yeah.
do you want to take a guess at what this is, or should I just tell you?
There is variant of salivary papillary
Like
with
a
mammary something.
mammary
Yeah.
analog secretory carcinoma.
Yes,
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 yes.
yep. So this is a secretory carcinoma of salivary gland type that is primarily originating in the thyroid. And so the two types of salivary carcinomas that are known to originate in the thyroid are secretory and mucoep. All right. So you can get those two types of salivary tumors primarily in the thyroid. This was especially a challenging one because it was called PTC on FNA, because it has papillary and follicular growth. And you could just go by it and say, yeah, okay, sure, it's PTC. But if you watch those subtle nuclear clues and the fact that something is just off, you should get to the right diagnosis. And so even though this was S100 negative, it was mammoglobin positive. What genetics did it have? You're welcome for sharing. What genetics did it have?
ETV6
Mhm. Yep.
NTRK.
Yep. So why do we care? Why is this such an important diagnosis to make, even though it's rare?
Treatment.
Treatment. What is this not going to respond to?
I mean, they do respond to NTRK inhibitors, right? I
Right, but are
think.
you going to throw an NTRK? If you call this a papillary thyroid carcinoma, are you going to throw an NTRK inhibitor at it? No, you're going to throw radioactive iodine on it.
No. Yeah,
and
so
it-
you'd want
yeah,
to avoid
It's
that.
not going to
Yes.
respond, exactly. So NTRK. So one, it's not a follicular derivation, which you have told by the Paxate, TTF1, and thyroglobulin. So it will not uptake iodine. It will not be responsive. So yeah, this patient needs some kind of other treatment, perhaps an NTRK inhibitor. So to be mindful, there are thyroid carcinomas that have NTRK rearrangement. So there are true NTRK rearranged thyroid cancers that are, PAX, TTF, positive. These are PTCs that can also be treated with NTRK inhibitors. But there is the NTRK, you know, secretory carcinoma that is PAX TTF negative, that is, you know, you know, of salivary origin, that, you know, does not respond to radioactive iodine, but will respond to the, you know, the TRK inhibitors. So in an NTRK rearranged true PTC, you know, you can still treat with RAI, but you cannot in this, okay? So, I mean, you can, but it's going to be useless. So this was a nice example, I think, of a rare tumor that really mimicked a PTC, but excuse me, has significant implications for patient treatment. So mucoep, I think, would be a little bit easier to diagnose, because you probably could see mucin and you're like, why is there mucin in here? And then you might go down the correct pathway, but you could also prove that with the mammal, you know, mammal gene rearrangement. So do you guys have other questions or comments? Hopefully that was helpful. That was a lot.
It was great though. Thank you.
Yeah, you're welcome. These are the things we see. I mean, these are the cases we see. You know, it's some of them are more rare than others, but I think, you know, you will see these. I will send out the updated link and put the recording on YouTube. So thank you guys.